Any other question from
Question from the audience?
From the audience? Yes.
Regarding hyponatremia in hemodialysis patient. Hyponatremia in hemodialysis patient. Some trick we must follow regarding this not normal patient, acute, chronic, mild, moderate, severe. Our dialysis patient.
Hyponatremia in hemodialysis is very complicated. It's one of the most complicated subjects in hyponatremia because the dialysis machine itself, you can only go to a sodium of 130, whereas you can have a patient with a sodium of 100. So if you dialyze somebody with a sodium of 100 against a dialysis fluid of 130, then potentially at the end of dialysis, the patient's sodium will be 130, right? So that means you have increased the patient's sodium in a 4-hour sessions by 30 millimoles per liter, which potentially is very, very dangerous. So if you want to know how to do dialysis, there are two options. One way is to do a very slow dialysis, to do dialysis for maybe 2 hours, and to do it at a very low blood flow rate. So instead of a blood flow rate of 400, you do it at 200 ml per hour, so that you reduce the diffusion of sodium from the dialysate into blood. And your aim should be to not to increase the sodium by more than 5 to 6 millimoles per liter per session. And I think if you reach that target of an increase in sodium by 5 millimoles per liter per day, then you are in the safe range, okay? If you want more information on how to do it, you can email me, and I will send you an Excel sheet on how to do the dialysis. It's very complicated as such.
Any other question? So my question to Dr. Anwar, I told you I have this question prepared for you, and you brought the issue of kidney transplanted the pig kidney. Do you think in the future this modification can be done on a human kidney and we can have like a global donor? Where's the mic?
Sorry, thank you. Our insight about what differentiates self and non-self is still not very well understood. Now, obviously, we know about the MHC complex. The whole MHC complex has not been mapped yet. We use the 6-8 antigen matching system, which we've been doing since the time of 1960s. Terasaki was the guy who first did that, and we've not actually evolved much. Now, if you look at the BMT program, they are going down to matching up to 4 decimals for each epitope. So what's happened is our medications have become so much stronger that I suspect we've got over the acute rejection, which what Bob Montgomery showed. But I think that's the first barrier. The second barrier is how do we ensure that tolerance and accommodation occurs over 10, 15, 20 years. I think that is still a huge unknown. I don't think it will come in my lifetime. And all xenotransplantation, we've been talking about this, as I showed, since 1960s, and it's always been told it's going to happen in the next 10 years. I think so. I want to say the same. It's going to probably happen in the next 10 to 20 years. And the people who follow me will also say it's going to happen in the next 10 to 20 years. I think we are still far away. Because you see, this is the primary reason we survive. What is native, what is foreign. And if we have to overcome this, I think so we'll have to increase our insight about how immune system works. And that'll be my spiel. Thank you.
Can I comment? I think there's some really interesting stuff and interesting work in xenotransplantation, and certainly some years back there was a lot of interest in how complement is different in animals and in humans, and there was a lot of work looking at transgenic animals to look at the way the complement system interacts, because the first thing that happens when you get hyperacute rejection is that the complement, you get complement activation. And so there's been a lot of strides worked out to get animals to have humanized complement. And you can get animal kidneys to survive for several days now in higher primates. We're still, as Dr. Siddique said, not at the point where we can consider xenotransplantation. But there are other things as well. Even if we get over the immunological barriers around animal viruses being transmitted to humans and other infectious complications, which we really haven't got our head around. So instead what we're doing is looking at the ways we can match human kidneys better. So the HLA system is a relatively crude way of looking at tissue typing. A lot of people are now looking at eplet matching, that is the single amino acid sequences or triplets of amino acid sequences and epitopes which are exposed when our immune system sees a foreign antigen. And sometimes if we can match those, even if the HLA types are completely different, we can have a successful transplant. So for patients who are highly sensitized, often who've had a kidney transplant before, or they've had pregnancy, we struggle to get those patients matched. And what we can now do is a combination of HLA matching and epitope matching and try and reduce the eplet load, which is different, and we can often get a successful transplant. Together with our understanding of how the immune system works and how we prime the antigen-presenting cells, I think we're in for the next 5 years for an explosion of really improved graft survival. And what I also should say is that in the meantime, we've got this kidney exchange program going, which Dr. Siddique was involved in the first ones, and now it's really going to get very big. And over the next few years here in the Emirates, I think we're going to see an explosion of the paired exchange program to transplant a lot more of our patients. In addition to which, our colleague, Dr. Ali Obeidli, has been doing a lot of work to try and change the law so that we can use deceased donor organs, and I think this is going to come in within the next year or so. And I think this is very exciting because suddenly we'll have a few more kidneys to offer patients.
The law is passed. In fact, we are already using the disease. Yes. Ah, okay. That's right. Right. True. True. If there is no more question, I think we ran out of time. So on behalf of my co-chair and myself, we'd like to thank all the speakers, including myself, for their excellent presentation. Thank you for listening. Bye-bye.